Welcome everyone. I am thrilled today to have my uncle here to have a discussion with him about the topic of this video series, which is what people of color or melanated people can do to avoid and survive the COVID virus, and also to thrive. And Dr. David Satcher graduated from Morehouse College in Atlanta in 1963 and was elected to Phi Beta Kappa. He received his MD and PhD in cellular biology from Case Western Reserve University in 1970. He was elected there to Alpha Omega Alpha Honor Society. He did his residency in family practice in Rochester, New York. And then he went to assume an administrative position at Drew in LA. He had a couple of simultaneous posts there that included being the CEO. And then he went back to Morehouse to help them start their medical school. And he worked with Dr. Sullivan there, Dr. Lewis Sullivan. And then he got interrupted while he was there, and was called for a crisis at Meharry Medical College because they were in danger of closing. And I was a student at Meharry a few years into his presidency there. So we were actually there at the same time. And he later went on to be the chief at the CDC. And then from there, he was confirmed as the 16th Surgeon General, while simultaneously holding the office of Assistant Secretary of Health. He published a landmark Surgeon General's report on mental health and another one on violence. He was known as the doctor who listens to the American people and who responds with effective programs. His mission was to make public health work for all people in this nation. He was not only a champion of promoting healthy lifestyles, but he lived it. And that's what I remember a lot about him from childhood, was that he was always living a healthy lifestyle and eating a healthy diet. He was a runner in past years. He played tennis. He loves gardening, swimming, reading, and he's a walker now. So, as I mentioned, the purpose of this video series was to look at what melanated people and people of color could do to survive and thrive after the COVID virus pandemic. I decided to do this series because I had a conversation with my parents regarding the virus and how it was getting here from China, and that it wasn't what it appeared to be in the media. People appeared to be focusing on the Chinese and thinking that the majority of people that were traveling here were probably Chinese. And in my thinking about it, when the pandemic first started, I did not believe that that was the case. My belief was that there were probably a lot of business people there, and I found out later that it was thousands of business people doing business there who were actually from the United States. And these people were probably not Asian, but probably Caucasian. And I realized immediately that there was going to be a disparity in the protocol for who was going to get tested and who wasn't going to get tested. Because when they were talking about the protocols for who was getting tested, part of that protocol was to ask who or where the person had traveled internationally. And if they had not traveled internationally in the beginning of the pandemic, then they were not getting tested. So that immediately created its disparity because there were people being exposed here who had not traveled. And now we see that that's absolutely the case because this virus is very contagious and it's been spread amongst a wide swath of people. I knew in the beginning, because of the mechanism of the way that the virus gets into the cell using the ACE2 receptor, that it was going to disproportionately affect melanated people because melanated people are the people who have health disparities. They have more obesity, overweight, diabetes, metabolic syndrome, and hypertension. And this is what the Chinese were documenting were predisposing factors for getting COVID virus. So, Uncle David, you've devoted your career to health equity. What is the title of your book and when is it going to be published? And can you talk a little bit about the book, hopefully without giving the whole thing away?
I don't fully understand the publication process yet, but it's everything is for the most part finished now. So the additional time is sort of standard.
Okay. And what are you talking about in the book?
Well, I start by talking about my own life and growing up in Alabama, both from the standpoint of my family that had such a tremendous impact on my life, my parents and my siblings. And then I also talk about segregation, discrimination, how that affected me. As you probably know, I almost died of whooping cough. And at that time, the hospital in Anniston did not admit Blacks. There was one Black physician in Anniston, Dr. Jackson, and he was the one that came when my dad went to see him. He came out to the farm. He didn't think I was going to live. He told them that I wouldn't live out the week, but I did. And it's a long story, but I talk about Dr. Jackson and the fact that I never really met him after I recovered because he died of stroke. He was 54 years old. He had been through a lot trying to practice medicine in Anniston.
Wow.
So I owe him a lot.
Mm-hmm. So, and I know you spent a lot of your career addressing health inequities and health equity. Some of that you're talking about, or a lot of that you're talking about in the book too?
Yeah, it's there's sort of three parts to the book. And I would say the first part is my growing up in Alabama and my family. The second part is something that started at Morehouse when I actually decided that I was not going to just be a victim of racism. I was going to confront it. So that led to jail and prison, but also a very rich environment at Morehouse. Dr. Benjamin Mays as president. And I used to walk the 5 miles to Martin Luther King Jr.'s church on Sunday. Not when I say I, there were about 5 of us who did this. And but because of things like sit-ins, we ended up going to jail and to prison on one occasion. In fact, I was in prison when Mrs. King called the Kennedys to get her husband out of jail. And so when that happened, all of us got out of jail. But I write about that because I feel like that was a major part of my development when I decided that, you know, I could fight back, I could make a difference if I were willing to pay the price. And the price could have been greater. So I consider myself fortunate that I survived the movement. I had a lot of other students. There were not as many students as people generally think, but there were several students who went to jail. paid that price. Students from Morehouse, students from Spelman, white students who came down just to get involved in the movement. And they would spend 6 months at Morehouse or 6 months at Spelman. So there were a lot of people who decided that they had to be a part of the solution.
Mm-hmm. Yeah, and so then the final part of the book is about how that influenced what you did.
Yeah, it's medicine. It's about how I approached medicine. And as you know, I ended up getting involved in research while I was at Morehouse. And I have to make the point that that wouldn't have happened if I didn't have to work to pay tuition. So I ended up getting jobs like the job in the laboratory where I was the assistant and with Dr. Hunter. And he's the first one that really started talking to me about my interest in research. And so I ended up applying to both graduate and medical school. And ended up going to Case Western on the MD PhD program. 7 years I spent there working on my combined degrees. Mm-hmm.
I didn't realize it was that long, but it generally does take that long.
Yeah.
Yeah.
I think in most cases it took people longer than that because the PhD part can certainly take more than 3 years. So I was fortunate to be able to finish in 7 years.
Mm-hmm.
So I graduated in 1970 after having started in 63.
Mm-hmm. Mm-hmm.
But a lot of the book is about my experience as a medical student. And, you know, I like to tell stories. And one of the favorites, there are two favorite stories, I'll be brief. One is about mental health and the Black patient that we went to see, and we were told we couldn't go in to see him because he was violent. And I asked the faculty if I could go back alone and see him. They hesitated, but decided that they would. So the nurses helped to get me in. But that was my first encounter with serious mental illness. And I finally got to the point, after he had attacked me a few times, I got to the point where we sat down and talked. We talked, and he started cooperating with the treatment. And it was such an in-depth encounter until the faculty members asked me to do grand rounds. And usually that means you present the patient and somebody discuss it. And they said, no, we want you to present the patient and discuss the problem because you spend so much time. So that was how I got interested in mental health. I didn't go into psychiatry, but I certainly got to the point where I was very interested. So as Surgeon General, all of that interest came together in the Surgeon General's report on mental health. It was actually the first time that the Surgeon General had done a report on mental health. Mm-hmm. But another story, which brings out another point, when I went back to the wards after a long period of research, the first rotation was OBGYN. Mm. And there were 9 students, and of course, as usual, I was the only Black student. So we walk in the room, and there is 4 Black women in stirrups. No curtains, nothing. They were told us that we were supposed to learn how to do the pelvic exam. I was amazed, I was surprised. And so I walked out, and the guy who was over the rotation, you know, he threatened me. He said he would see that not only would I be put out of Case Western, but he would see that I never got into any other medical school. So that was his bluff. So, but I must admit, I didn't sleep that night. So the next morning, I was scheduled to go see the dean. And the dean was Fred Robbins, who would play a major part in my life. Even after I got to Meharry, he joined the board there. But when I went to see him, he said, sort of jokingly, David, I understand you got into some trouble yesterday. I said, yeah, I guess I did. He said, well, do you know what happened this morning? And I said, no. He said, well, the other students walked out and they said that they agreed with you, that it was inhumane treatment. And then he said, David, we're going to have to change that program. And that was sort of the beginning of changing that program and a lot of other things. But he talked about that at commencement.
Wow.
Talked about civil rights and the contribution I had made to the environment.
Wow. Yeah.
But I was blessed. I could have been put out of school.
Mm-hmm.
But I make another point in the book, though, because the part so far that makes me look good. But when you think about the fact that I could have been put out of school, if I had stopped and talked with the other students before I walked out, then it might well be that we would all walk out together. But I didn't take the time, so I don't think that's good leadership. I make the point that even though I like the way it worked out, I don't consider that good leadership. I should have first talked with the other students and to see. I assume that they didn't care. The fact of the matter is they did. They cared enough to walk out the next day. I learned a lesson there, because it was bias on my part to think that, that they were supportive of the kind of thing that was happening there.
Mm-hmm. Mm-hmm.
But if they hadn't walked out, I don't know what would have happened.
Well, I'm so glad you told that story because I hadn't heard that story.
And most people haven't, but I write about it in the book.
Yeah. So you mentioned Morehouse, and I didn't talk about your position at Morehouse. Would you mind talking about that a little bit? And a lot of people are always asking me what you're doing and what you're up to. So.
Well, before I do that, though, in fairness, I have to mention Drew.
Okay.
Right. In 1972, I believe, but it was after I had done a mixed medicine pediatric program at Rochester, University of Rochester, Strong Memorial Hospital. I heard about the development of this new medical center in Watts. And, we had the Watts riots, and so this was a big thing. I was getting a little frustrated, of course, being at a predominantly white institution where I was the one. I spent so much time being the only one or the one of only two. So I decided that I was going to take this opportunity. So I decided to leave and go out to Watts. I met Dr. Haynes, who was over community medicine, and we were able to get me a Macy fellowship. So I went out to Watts as a Macy faculty fellow and spent a few years working in community medicine, then spent some time at UCLA as a Robert Wood Johnson clinical scholar. And then Drew ran into problems and people questioned whether it was going to survive. And it was in that environment that they talked me into serving as dean and CEO. Some people say that I have a tendency to respond to crises. And I guess so. Not that I like crises, but there's something about crisis. If I think I can solve the problem, I tend to respond. It was the same thing that led me to Meharry, really, because the New York Times had this big article saying that Meharry was going to close. And it talked about all of the things that the institution had done. And by that time, I was at Morehouse. Lou Sullivan had asked me to join him to get the medical school started at Morehouse. But then people started asking me about Meharry, and several of the people who worked with me out at Drew, some of them were Meharry graduates, Ezra Davis and some others. So they ended up asking me to consider the presidency at Meharry. And I immediately said no. I was just getting started at Morehouse. I just started a residency program there in family medicine. But that continued. So finally I agreed to go for the interview. I said, well, at least I'll go for the interview. And it was really in that process of learning about Meharry and going to visit that I decided that I didn't have anything more important to do than if I could make a difference at Meharry. So it was that that led me to leave Morehouse, which was not easy, and to go to Meharry. And the rest has its own history.
Yeah. Yeah.
But I was blessed there.
Mm-hmm. So what are you doing now at Morehouse?
Well, I'm actually retired from Morehouse. It's sort of strange because, the president said she wanted me to keep my office and said as long as she was president, that was my office. And I appreciated that. I'm not sure how long I'll keep it, but I do have an office there and I used it. I used it a lot when I was writing, but I also do a lot of teaching. I don't just use it for myself. I teach in the fellowship program and some of the other programs. I give grand rounds in medicine over at Grady and stuff like that.
Okay. Okay. I didn't know you were over at Grady too.
Well, I'm not there a lot,
Uh-huh.
but
Go up sometimes.
Yolanda Wimberly, you know Dr. Wimberly?
Yes. Uh-huh.
Yeah, well, she came to Morehouse to the Satcher Health Leadership Institute. So when she came, she spent the first, I believe, 2 years with us.
Mm-hmm.
And then something happened and she ended up at Grady with the Department of Pediatrics, and she's become a leader over there. She's outstanding. I enjoy working with her.
That's cool.
Mhm.
So we're going to talk a little bit about the COVID pandemic, and many people are curious about the strategic stockpiles. We had not heard much about them before, and I personally noticed that certain medical supplies and supplements started disappearing in January from the market. Can you talk about the strategic stockpile and how it was utilized strategically in the past? Why was it created and who usually determines how it's used?
Well, let me admit at the outset that I don't know a lot in detail about the stockpile. I mean, I do know that in this country, we try to be prepared for emergencies, and that might well mean getting FEMA to help, rebuild the community like they did in New Orleans, or it might well be getting the National Guard to go to a community to play a role that others are not prepared to play. Stockpile is there to be used as needed, at the state or even at the local level, but that would go through the state. So I think it's a wise idea to have a stockpile that can be used in a critical situation. There's been a lot of debate recently when one of the president's people said, this belongs to us, it doesn't belong to you. So a big debate started. The fact of the matter is, it was there to be used as needed throughout the country. And, there should be no debate about, who controls it. It's a national stockpile.
Mm-hmm. And you were saying like the military can get involved at the state level and the national level?
Yeah, well, the governors can order the National Guard. I mean, I think that's been true. Always the governors can call out the National Guards as needed in their states. And that's because I guess the governors are supposed to be in the best position to determine the magnitude of their needs and the seriousness of it.
Mm-hmm.
So the governors do have a role. The debate will always go on about who has the greatest power over it.
Yeah, and I guess the National Guard tends to work with FEMA, whether it's national or local, right?
Yeah. The best example was probably New Orleans and after Hurricane Katrina.
Okay. And are there policies in place for expanding the strategic workforce in times of health crisis?
Well, yes and no, but as we have learned, the policies are debatable. The policy is debatable in terms of who controls what when. But yeah, the intention is that there is in this country this opportunity to respond to critical needs at the state level. And it is technically a central resource, but it doesn't mean that governors cannot call for that support in times of crisis. Luckily, they can.
Mm-hmm.
Uh, but you would think that in a situation like this, everybody would want the authority to be central. But as you know, that doesn't always work well. It depends on the attitude of the central people, I should say.
And so when you say central, I'm just clarifying, you mean the federal level, right?
Yeah, the presidency, and yeah, I mean, I think um, governors are in a position to best know the needs of the states.
Mm-hmm.
And the closer they are to the states, and well, we couldn't have a better example than we have right now,
Mm-hmm.
with the pandemic,
Mm-hmm.
and the needs of the states. And every governor has to be clear about what he or she needs. The president has to play a role, but the plan was that it would be a cooperative venture.
Mm-hmm. And I remember also learning in the past that the branches of the military, like they have medical capacity within the branches of the military that can be utilized in this type of situation as well, right?
Yeah, well, there's even a surgeon general of the Army and Navy, and so yeah, they have their own medical personnel and capacities. Yeah.
And I remember, because I also remember, other than the surgeon generals, that they have kind of like equivalent to the CDC in the military, kind of like a section that like looks at infectious disease and.
Yeah, but there is no equivalent to the CDC.
Right.
No, I could talk about that because we're experiencing that right now with the WHO thing.
Mm-hmm.
I don't know how many people are aware of the critical role that the CDC working with WHO, how critical that role has been.
Mm-hmm.
It's a very, and the fact that the United States contributes more than any other country has never before created a problem. It's been an asset. The United States has been appreciated for that throughout the world. So it was the CDC and the WHO that worked together to eradicate smallpox disease, one of the greatest, I shouldn't say one of them, the greatest public health contribution in history. But so that relationship between the CDC and WHO is based in great part not just the fact that the United States has more money than other people and pays more to WHO, but because the United States has always been viewed as caring and dependable, and it's really been an asset for us as a nation. I served as delegate to the World Health Organization for 8 years in a row. I started when I was president of Meharry, but I was asked to work with Mrs. Clinton on developing the health reform plan that she developed.
Yes,
And
I
it was and it was 1 year that it was soon after they got in office, but they had forgotten to designate somebody to serve as delegate to the WHO. And it was sort of like the last minute, less than 2 weeks. And I was president of Meharry, but they asked me to serve as delegate to WHO, and I did. And that was the beginning of a relationship that would go on for about 8 years.
Mm-hmm.
I have great admiration for WHO.
Mm-hmm.
In great part because of, there's so many different countries involved. People work together as a team. They respect each other. But I've never known the United States to say, well, we're paying all this money, because states, countries pay money based on their ability. And
And it's a cooperative effort. Like one of my close friends worked at WHO for a while, and I got the privilege to go like tour the facility in Switzerland when I was visiting there.
Yeah.
But it's so integral to just the health of the whole world.
Oh, yeah.
And then also the United States not only provides funds, but they provide leadership to the WHO. Like we have scientists and we have doctors working at WHO.
Yeah, and in responding to crisis, when I was director of the CDC, one of the things I remember most vividly was the Ebola outbreak in Zaire, very serious. By the time that we got involved, I think there had been 250 deaths already, most of them people who worked in the hospital there. The thing about Ebola, of course, that's different from COVID-19, of course, is that Ebola doesn't spread that far, that fast. But COVID-19, as you know, is the most rapidly spreading, if not one of the most rapidly spreading diseases. But I do remember that the WHO called upon us to develop a team to send over there. And I was concerned that since so many people had already died, we'd have trouble getting people to agree to go. I was overwhelmed with people wanting to go, wanting to go to Zaire to fight Ebola. So we ended up sending a team of 10 people over there, and they successfully put that particular outbreak to rest. But that's the attitude of people at the CDC. I mean, look at smallpox, the eradication of smallpox. It was the CDC working with WHO, and the CDC actually gets most of the credit for the eradication of smallpox, which took place in the late 70s, and WHO declared it eradicated in 1980.
Right. So, wow, that's really informative, and I think people are going to be interested in those facts. I'm going to switch to the individual, and how can people of color prepare themselves in terms of health, and how can they avoid getting the virus?
Well, let me just say, another report that I did as Surgeon General that's relevant to your question is the report on overweight and obesity, focusing primarily on what we needed to do with children in terms of nutrition and physical activity and the role that the schools play. Because many of the children come from communities where they don't have access to parks, or they may not even have access to healthy foods. And if they do, they don't have anybody who has the time to monitor them to make sure, at least nobody who can use that portion of their time that way. So school is very important, and when it comes to the health of children. So, well, I got involved in that and I forgot your question.
No, that's okay. I was asking about the COVID virus and how the individual could avoid getting it, and how they could, how they can maintain their health in this situation.
Yeah, I know why I got off got on that tangent, because it's not really a tangent.
It's
But
not, yeah, it wasn't a tangent.
no, it was related to the fact that African Americans are much more likely to be overweight and obese. If a child is overweight and obese by the age of 12, there's an 80% chance that that person will grow up to be, obese as an adult. You can go on and on with that, the importance of what happens in childhood. And the best opportunity we have, in my opinion, as we said in the report, is to really try to impact the lifestyle and behavior of children. I'm not saying adults is very important, but that's late. Obviously once one becomes an adult, it's not as easy to change their lifestyle. And it's more difficult to reverse things like obesity. So there's a lot to be said for what can be done in childhood to prevent some of the predisposing factors to the COVID-19.
Mm-hmm.
COVID-19 is, as we very well know, is much more likely to infect somebody who is obese, has diabetes or cancer or heart disease.
Mm-hmm.
And there's a relationship with vitamin D, there too.
Mm-hmm.
So all of those things ought to come together. And so when something happens, like you discover all of a sudden that African Americans are overly represented in the population of people with the COVID virus. And, at first, it's a scary thing at first. And then you start thinking about it. Is this a different story? Or is this more of the same story that we've been talking about? But maybe we haven't taken seriously enough yet. So I would like to take this opportunity to reemphasize that we need to get serious about eliminating disparities in health. We, not just Black people or Latino people, we, the United States,
Mm-hmm.
need to get serious about eliminating disparities in health. That was one of the goals of Healthy People 2010,
Mm-hmm.
the elimination of disparities in health.
Mm-hmm.
But that's what's going on with COVID-19. For the most part, it is, I think, the virus targeting predisposing factors.
Mm-hmm.
Mm-hmm.
So I've been frustrated with seeing the press and others acting like the health disparities and inequities that are presenting themselves are some puzzle that no one understands the cause of. You've been inextricably connected to the entire field of health disparities research. And we know from three decades at least of research that many of the root causes link back to slavery and Jim Crow policies of our government, and now institutional racism. Can you say a little bit more? Because I noticed just this past week that there was a speaker on one of the news stations who was talking about, African Americans and Native Americans, maybe the health disparities are self-inflicted. Maybe it's because they're drinking and smoking. And I've heard this more than once over the past week, which is, that's distressing. And I know that these groups, they each have their unique suffering, is what I would say. Because Native Americans, Latinos, even Asians in this country going back in time, and African Americans have undergone oppression or some kind of abuse.
Yeah, and that price has not been paid. In other words, we've changed a lot of things in this country, but nobody has said, because of all those years in which you worked for nothing, or you worked and got cheated out of your money, or in the case of my dad, who worked in the foundry for 55 years and knew more about fixing the sand than anybody, could not get the job of driving the sand machine. And they were very open about it. They said, this is not a job for a Black man. They had jobs, where Blacks could not get the job because they were Black.
Mm-hmm.
And I grew up watching that, and seeing how he handled it, which I still marvel at.
Mm-hmm. But what I guess what I wanted to say, or what I want people to understand, is that the consequences of that abuse and oppression drives mental health problems. It drives drug abuse. It drives, addictions like tobacco. It drives addictions to foods that are not nutrient dense. So foods that cause obesity are addicting. So we're in a quagmire or in a situation where, you know, the psychosocial issues in this country for 400 plus years have driven us to where we are now with the health disparities. And it has not been disrupted or changed, like you said, because it hasn't really been acknowledged.
No,
Mhm.
it's critical. It's um, and we don't have the answer yet. That's what frustrates me. Is and every time we make significant progress, you know, like Obama and the Affordable Care Act, and which was meant to be a beginning, and instead, there are people in Washington trying to reverse even that progress.
Mhm.
It's and so you get set back again. It's almost like you start all over again. Uh,
Mhm.
this is very serious. It's going to take something almost revolutionary, I think, to change it, to really make a change in the way this country deals with African Americans and Native Americans. I
Mhm.
remember asking when I was director of the CDC, we were in Newt Gingrech's district, and I didn't know him, you know, but we decided that we were going to do this project to target diabetes in Native Americans. It was a well thought out plan. It was our National Center for Chronic Disease and Prevention, et cetera. And so it was going to take a lot of money. I think the initial request was $200 million. And I don't know if they had ever spent that kind of money on the Native Americans before. But so we went and met with Congressman Gendrich. He was in the position that Nancy Pelosi is in now. He was the power in the House. And so I was a little nervous. I mean, you know, I hadn't even met the guy before. And so we went and I was told, you know, you better talk fast because he's not going to give you more than 10 minutes. So we went and we presented. He took off his coat, well, and I didn't realize what was going on, but he was so interested because he had family members with diabetes, and even though we were talking about Native Americans, American Indians, he was very interested. The bottom line is he took it back to Washington. He got more than $200 million. And there's an MMWR article about the difference that that project made uh, in terms of dealing with diabetes in the American Indian population, Native Americans. But things like that are kept too quiet because it showed that it was possible to make significant progress in dealing with some of the problems on the reservation. We still have a long ways to go.
Mhm.
Nobody has, I don't know how the Native Americans are doing with this virus.
Oh,
But
there have been reports they're doing poorly. Uh,
that's what I would figure. Yeah.
yeah, yeah. They're having significant mortality. It's been reported. They
Yes.
don't have all the, you know, as you know, they weren't breaking out race numbers initially, so um,
Yeah.
playing catch up. But the numbers that they had from some of the nations, the Indian nations, yeah. Hmm.
Yeah. I would think that I'd be happy when they finalize those numbers because I think this is important.
Hmm. So, do you have any? You've already alluded to some of this, but do you have any recommendations for leaders regarding addressing health disparities in their communities and preparing for this pandemic and for the future? Really, the future pandemics, because this is not going to be the last one that we see.
Yeah. Let me put it this way. I've already told you probably more than I should have about the book, but it's okay. I think we're to the point now where we can begin to talk more about the book. Um, but much of the book is about leadership in
Oh, okay, okay,
in the specific and in the abstract.
okay.
Much of it, I mean, it's about leadership in terms of policy and practice, leadership and communication, leadership as a team sport. Much of the book is about that. And then around there are these stories of experiences, that I had at Drew, at Meharry, at Morehouse, as Surgeon General. Now, I talk about women and leadership because I had some very rich experiences when I went to the CDC. Of course, there had not been a woman director or deputy director or institute director. And I selected Claire Broom as my deputy, who at the time happened to be 8 months pregnant. So, so I remember that. And Claire, she was amazing. She had done some really good research on things dealing with the health of women. And so she delivered and came back and did things like develop the first breast pumping center at the CDC, things she was going through, and therefore had a special appreciation for the need and the difference it could make for women. Together, we selected Helene Gale to, number one, we pulled all of the AIDS programs together. There were 8 different AIDS programs. And we had a committee to pull them all together, and Helene Gale was the person selected to head that. And the rest is history, I can say that. She turned out to be a great leader in a lot of ways, nationally and globally. And is now head of the Chicago Foundation. But there were several examples of, leadership decisions that I think made a difference and impacted the plight of women, the plight of minorities, not just at the CDC, but in this country and in the world. But it's not a book where I'm saying I'm satisfied with my leadership. I'm not, never have been, but I learned a lot of really good lessons.
That's superb. And I just will interject that one of my friends sent me an article yesterday, and it was an article talking about that the countries led by women have better COVID numbers.
Yeah, I saw that. But now we're seeing more and more things like that, and the difference that it makes when women are in leadership. It's like with African Americans, what we've gone through when we become leaders, hopefully, and I'm looking at all these women and African Americans heading these cities where this problem is. So it makes a difference what you've been through.
Because I think it lends, and especially from your story, and I hope people will purchase your book, because I think that it lends empathy and altruism to leadership. And I think that's important in this age of leadership anyways.
Well, Serena, I hope people will purchase my book too. I think they will. But mainly I hope people read it, because I think we learn a lot, and, stopping and trying to put together what you've learned is not an easy thing to do. And much of this for me occurred, when my wife, Nola, was in the last years of her illness. And so writing, I guess, was something I did because I didn't want to do anything else.
So do you have any parting statements or any other subjects that you'd like to discuss before we get off?
Well, I mentioned my wife, Nola, and that, obviously taught me a lot about caregiving and also about the health system and all of its deficiencies and problems and what it does to people. I mean, people who don't have the resources I have, and yet have to take care of loved ones and stuff like that. Our system is does not live up to what we stand for as a nation. Our health system does not. And I think until we make that change, until we have a health system that matches our commitment, or what we say is our commitment to people, and I think, so hopefully that comes true also.
Mm-hmm. Okay.